Hello. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled OSHA Common COVID-19 Citations and Revised Guidance. My name is Michelle, and I'll be your moderator for this program. A copy of today's slides is available using the link provided in the chat box. The chat box can be found by clicking on the chat button in the lower right corner of your screen, and you can see the chat bubble. The webinar will be available in a few weeks on the Patient Safety Authority's YouTube channel. We are recording this session. We welcome any comments or questions you have. You can enter those in the Q&A box or the chat box on the right-hand side of your screen at any time during the presentation, and we will have time at the end to answer some of them. All materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar. Miss Isabel De Oliveira is she's been with the U.S. Department of Labor, Occupational Safety and Health Administration for over 20 years. She started as an industrial hygienist, compliance, safety, and health officer, performing worksite safety and health inspections and evaluations throughout all of New Jersey, New York City, including numerous in the healthcare industry. In June of 2010, Isabel began providing outreach services as the Regional Compliance Assistant Specialist for the Philadelphia Regional Office. She coordinates all federal outreach activities in Delaware, Maryland, Pennsylvania, Virginia, West Virginia, and Washington, D.C. So she is a busy lady, and we are thrilled to have her here with us today. Isabel, I'll turn the program over to you.
Okay. So the information we're going to be covering today is really no way to make you an OSHA expert. Again, this document is being provided to just provide clarity to the public regarding existing requirements under the laws that all employees should be providing a safe and healthy workplace. So moving on. Again, as the ladies so lovely introduced me, I am the Regional Compliance Assistant Specialist as well as Coordinator for the Philadelphia region. Today we're going to be comparing OSHA's top 10 violations for all industries in fiscal year 2020, and I will give the parameters of when the data report was run, and then comparing that to the top 10 for the healthcare NAICS. We'll be describing the common citations relating to COVID-19, and then as we were planning this session, lo and behold, the National Emphasis Program for COVID-19 was published on March 12th, 2021, so we'll be covering that. And because I'm a compliance assistant specialist, there would be no presentation without some identifying and sharing the compliance assistant resources. I believe this information was shared either directly to the registrants and or is available in that linked location. OSHA, since 1970, we have recently celebrated our 50th year, is a balanced approach. It is for enforcement as well as outreach and consultation. We'll be covering consultation extensively in the Compliance Assistance Resource section of this presentation. And then sessions like today, where compliance assistants or OSHA staff will provide material in sort of a virtual yet live format. Here are the citations that were issued during fiscal year 2020. Unfortunately, our number one hazard for many years now has been fall protection. It is a construction regulation. You can note that by using the 1926 Code of Federal Regulations, and about 50% of the top 10 is in construction specifically, so construction work sites. Historically, for about 10 plus years now, hazardous communication was the number 2 citation. It was bumped out of that number 2 spot by, again, not unexpectedly during a pandemic, the respiratory protection requirement. We're going to dive into this requirement a little bit deeper as to which sections were issued, subsections. Rounding out the top 10, we have scaffolding, lockout tag-out for energy control, ladders, but ladders in construction, powered industrial trucks, fall protection, its training requirements, and eye protection, face protection, again in construction, and then the machine guarding regulations. Historically, healthcare did not receive as many inspections per year And so the data was compiled for 3 years of data. It still has all of the issued citations for fiscal year 2020. And again, I compared it to last year's 3-year running report, and it wasn't very different. But between this and then the review of the Common Citations document, you'll be able to better get your facility into better compliance. For the number 1 citation, and we're going to go into the 5 subsections of each of these. So this slide will be, again, divided up into 10 more slides. So we have bloodborne pathogens, still the number 1 citation in healthcare, hazardous communication, reporting fatalities, hospitalizations, amputations, and loss of an eye, electrical hazards in the general requirements, personal protective equipment. Once again, it's general requirements, respiratory protection. Interestingly, in healthcare is only number 6, most cited citation. Number 7 is lockout tagout, and the record-keeping forms and recording criteria. We'll be getting into that a little bit because we do seem to find that a bit more during the COVID pandemic inspections. Electrical wiring methods, and then the exit routes. What we have here is a non-numerical sequential citation. So again, for the next 10 slides, you'll see which was the number 1 citation, which in this case for bloodborne pathogens was just the written exposure control plan. Yes, there is a requirement for a written exposure control plan. If done well, it will then have the elements that come underneath it as well, which means training employees with occupational exposures, reviewing and updating the exposure plan annually, and then documenting that. The employer shall assure that employees who decline to accept the hepatitis B vaccination are offered the signed statement for, again, a declination. And this is a case of it may just have been a paperwork issue that had not been done, and or more and more of the employees of healthcare facilities already have the hepatitis B vaccination from previous offerings, be it coming up through high school, college, as well as nursing school or other trades in healthcare. But the declination form is still something that is going to be required under the bloodborne pathogen standard. Engineering controls and work practices, again, recapping is not allowed, has not been allowed for quite a number of years, but selecting the proper engineering control, and in this case, technology has evolved, so reevaluating engineering controls as well. The number 2 citation, and this regulation was updated in HASCOM 2012, and we're going to get further into it, these top 3, because I wanted to make sure that the facilities had a taste of what better training and what the elements that are needed. We're going to be covering them a little bit more detail than just these top 5 hazards and citations. Once again, the written hazardous communication program was not available for review by the compliance officer as required by the regulation. The employee information and training must be provided in a language and a manner that the worker understands. If the worker's primary language is not English, the compliance officer will assess that and be documenting the deficiencies accordingly. Maintaining copies of the safety data sheets in the workplace and ensuring that they're readily available to the employees as well as accessible to the compliance officer at the time of an inspection. Having safety data sheets for each hazardous chemical. And the 5th most cited is the elements of the hazardous communication program is the list of hazardous chemicals. I would say that the list of hazardous chemicals is really at the center of a hazardous communication program. The reason being is with that list, you will know the quantities of the chemicals that you have at your work site, how often you are likely to reorder based on the quantities of those chemicals at your work site. It be it disinfectants or cylinders or tankers or totes or something in the middle. Any chemical that's at the work site should be listed on that hazard chemical list. You can do your ordering off of it. This is where, okay, can you categorize these chemicals? Are they cleaners? Are they used in direct patient care, or so on and so forth? So that list becomes very, very important and can be used to effectively do your whole hazardous communication program. I will just do a bit of information that the Federal Register is proposing some revised rulemaking of hazardous communication to better align it with GHS. And again, we'll get into that a little bit later on. So the top third citation in healthcare over the last 3 years, and these are all healthcare codes, not just long-term care facilities, resident care, or what have you. We compiled all the data for all healthcare facilities, being the most effective way to transmit the information to stakeholders. 1904-39 is a fairly new regulation, but again, it's over 5-6 years old now. Reporting fatalities, hospitalizations, amputations, and losses of an eye are a requirement for any and all employers. It is not just for healthcare, but again, it's not being done as necessary in this industry. Within 24 hours of the hospitalization, inpatient hospitalization, not just emergency room, amputation, which could even be a fingertip soft tissue amputation, and loss of an eye would be required to be reported. Also not being reported to the OSHA is within 8 hours of a work-related death. Now, if it's unclear whether the work-relatedness of, say, a heart attack or motor vehicle accident, is it on the road, or was the worker in work status? More often than not, it is better to do the reporting and then let us make the assessment during what's considered an investigation, not necessarily an in-person inspection. Again, we have resource allocation issues as well. So not every report gets an inspection. So there is that, but the report is a requirement of the regulation. The items which make a basic report were not submitted at the time of reporting. There is an online method of reporting, as well as the 1-800-321-6742, which is a 24-hour, 7-day-a-week reporting system that the employer can use. The methods of reporting, again, there's the 1-800 number, there's the local area office. In federal jurisdiction, state equivalents would apply as well. For example, in this Mid-Atlantic region, Maryland and Virginia are state plan states. They have the same regulation. If you have sister facilities in those states, that you would have to report to them. You can still go through the 1-800 number, because by putting in your zip code, it'll get you to that correct area office. And then the procedure, if not learned of probable incident right away, you have to report it as soon as you learn about it in a management position. So, regulation number 4, if you have electrical and general requirements, again, having an electrician on staff, having someone that you can rely on to be in compliance with the electrical regulations, installing and using listed or labeled equipment in accordance with the instructions listed or labeled, sufficient access and workspace about the electrical equipment for 600 volts or less, no use of working space for storage and guarding of workspace, marking your service feeders and branch circuits at their disconnect, and again, this sort of relates back to lockout tagout, and guarding of live parts. Personal protective equipment. When employers have chosen not to use the most effective means of controlling hazards at the workplace, engineering controls, administrative controls, and have selected personal protective equipment, they have to make a hazard assessment of why that personal protective equipment is being used, be it for your face, your head, respirator, respiratory, audible, audio, noise, as well as body and other coverings. So there needs to be a written certification of that hazard assessment, and it needs to be signed off by an executive of the company. When personal protective equipment is provided, it must be in accordance with that hazard assessment as to why that equipment was selected. And if it's not available, then the PPE that is provided needs to be as effective, if not more effective, to protect the employees from the hazards. Now, the selection and use of PPE to protect against the hazards identified in that hazard assessment. Again, during a pandemic, it was clear last March, April, May that some supplies of PPE were of an issue and a concern. So yes, there was some enforcement memos that were provided, and we'll get into that a little bit during the review of the common hazards. But now we're in year 2 of the pandemic, and supplies are readily available for personal protective equipment. So the training of employees required to use the PPE, again, I would make the notation here about it being in a manner and a training level, education level, and language that the worker understands. Respiratory protection. Respiratory protection. The top 5 sections of the respiratory protection in the healthcare industry in the last 3 years were, once again, written respiratory protection program. Again, there could have been a time where facilities used the voluntary use of a filtering face piece, but during a pandemic made the choice to, for example, use that upper right picture of the elastomeric respirator with cartridges. That is a much more substantive respiratory protection form of protection, but the employer needs to have a written respiratory protection program. And the elements and some of the components that go with it are that medical evaluation to determine the employee's ability to use a respirator. And we'll get into that a little bit more with the review of the common citations. Providing respirators at the request of employees or permitting employees to use their own respirators. Employer is allowed to do that. It is allowed by the standard, but the employer needs to make sure it is going to be protective for what the chemical or exposure is. Respiratory selection must be based on the respiratory hazards in the workplace. And then the fifth most frequent cited element was that the face piece respirator pass was a qualitative fit test or a quantitative fit test. Couldn't just hand off a respirator and say, here, use this for the next week or so and not review the appropriate fit testingness of the respirator. I will take a pause here and say that CDC and OSHA and Niosh have a little bit of a different language. OSHA will try to use terms like elastomeric respirator, filtering face piece. Surgical masks, very narrow use, again, back in March 2020, April, May, June, but we are now in March 2021, so different time frame. And then the cloth face covers. Cloth face covers are not approved respiratory protection as per 1910-134. So there is that. Lockout, tagout, energy control. Developing, documenting, and utilizing energy control procedures as required for protecting the employees. Periodic inspection of an energy control program must be done at least annually, and it was not being done. Once again, training on the energy control program in a manner that the worker understands. Training on energy control that includes the recognition of that hazardous energy source, not just electricity, types and magnitude of energy available in the workplace, and the method and means necessary for that not only isolation but control, and almost like checking to see if you've discharged all the stored energy. And lastly, the energy control program will have the elements that include the procedures, the training, and the periodic inspections. I will take a pause here as well to say that not only are the employees who use locks need to be trained on the program, but your other staff needs to recognize what it means to have a lock on something. So there's what we call exposed employees or authorized employees or affected employees. So again, the language is very specific to the lockout tagout standard, and it would be something that the employer would have to be compliant with. Record keeping forms and recording criteria. I will just say that we are probably not going to cover this sufficiently for a lot of the worker facilities on this call to be satisfied with the depth that we will go into. But know that there's resources on the website as to what could be recorded, not, and we'll get into a couple of examples, but just a few. We couldn't possibly do it justice. It could have its own 2-hour session, really. But completing the OSHA 300 log, again, facilities that have 10 or more employees are required to maintain not only the 300 log, but all of the other forms that are be required. The forms are available on the OSHA website under record keeping forms. The time limit for recording each injury, it needs to be recorded within 7 business days. My recommendation is always to be a little bit more conservative. Record it as soon as the employers are notified of it. Create a 301, which is the accident equivalent page. And then if there's a determination for it not to be work-related, then you could line it out. That's the better way to go versus something that happened to me a number of years ago that I was working building management. I closed down my building. I pulled down one of the cages, slammed my hand underneath the cage, thought nothing of it, did not write it in the ledger to close out my day. Next morning, I woke up, my hand was still swollen, and I'm like, oh, that's not good. So again, I brought it to the attention of my boss right away. Luckily, they did the prudent thing and sent me to the occupational health clinic and got my hand x-rayed. But again, as soon as they were notified, they did the right thing. That's the point of the story. For example, I will also mention loss of consciousness here. Again, some facilities are now doing vaccinations. They're even doing them in-house, bringing the vaccinations to the facility. Should your employee have a loss of consciousness, that's recordable. Again, workers' compensation and OSHA recordability are not always 100% overlapping. So please be aware of the subtle differences between those two. Again, a state requirement, Commonwealth requirement, and also the federal OSHA requirement for record keeping. Number 4 was when not to put employees' names on for the privacy reasons. Again, needle sticks, assaults, sexual assault, I believe, but again, I just typically just say assaults, and those are listed for the 29B6 of the privacy reasons. And then the when to complete the 301. Again, more often than not, even like a near miss, if it involves an employee, maybe not property, but person, always best to have a 301 incident report for reasons of, again, thinking nothing of the injury or the possible injury today. A couple of weeks later, I come back and say, you know what, I think I might have that sprain strain, but the exposure, you know, was 3 weeks ago. So again, it's almost always better to record rather than not, or have the report on record. Back to electrical. This is more for wiring and boxes and providing pull boxes, junction boxes, fittings, covers, identifying for the purpose. Not using flexible cords and cables as a substitute for the fixed wiring of the structure. This was really something I saw late last fall into winter when, again, the holiday decorations went up much earlier than in previous years. Again, you don't want to be anywhere near the 45 days if you can help it. Again, fixed wiring is much better than the use of extension cords and or flexible cords in substitute. Connecting flexible cords, cables to devices and fittings so that there's a strain relief to prevent and pull directly from the joints or the terminal screws. And again, it's very specific. We could have a whole session on just electrical and what that would look like. But again, there is that language. You can always refer back to the regulation. Conduits and conductors need to enter the boxes, cabinets, and fittings in a specific way. And then when entering cutout boxes, cabinets, or fittings, they shall be protected from abrasions and openings so that the conductor entering shall be effectively closed. Number 10, exits. Again, it actually warms my heart that exits are very low on the list because exits are so important in emergencies. Exits do need to be marked, visible, and with an exit sign. They need to be free and unobstructed. We'll draw attention here to the very snowy winter we had here in Pennsylvania. Again, you might be calling in outside of Pennsylvania, but when clearing snow from sidewalks and such and walkways, the exit route from an exit may have been used, or a ramp may have been used to store or, put the snow. So again, it's not just the exit route being free and unobstructed, it's also the discharge point on the exit side. Again, in the fall, it's the leaves that can make a slippery path. So something to be mindful of and prudent during your walkarounds of your facilities. Direction of travel to an exit or the exit discharge was not clear or very identifiable. Markings of doorways, passages, and along the exit routes shall not be mistaken for an exit. Again, the unexpected time where you'll be on the floor crawling to an exit, you may want to consider using different demarcations near the floor so that it is identifiable. That is but one example. Each exit must be adequately lit so that the employee with normal vision can see along the route to the exit. If you have not been inspected recently, may I commend you on being OSHA compliant. If you haven't, then you may not have realized that OSHA has updated its penalties, probably running around that 2016 timeframe, and every year since then it is now linked to cost of living. So penalties assessed in and around January 15th every year will uptick a little bit. So now we were at a $13,653 for a violation, for a serious violation. Failure to abate are running around that same area per day. And willfuls or repeats are 136,000. So when I had started with the agency, they were in the range of 7,000 and 70,000. So we certainly have changed the penalties. I often have heard some employers or certain advocates for safety at the facility say, oh, the rate of return isn't going to be very high. My employer isn't, giving me the dollars for this or that. And I said, well, you can always show them the penalty amounts, and then they can compare whether or not they would rather pay for the engineering control or pay for the penalty. So now we will go forth and share some of the common COVID-19 citations. This document was published in December of 2020. It's a 6-page document, and I don't recommend printing it. What I recommend having it on the computer screen, because within the Adobe, this is my Adobe application, it happens to have the links to the different resource sheets that I'll be mentioning, some of which, again, has a lot more of what you want to go back to. Again, if you're so concerned at your facility about the COVID citations or what could be coming with a possible NEP, National Emphasis Program inspection, here would be the ones that we have been finding. These are only intended to help, again, better understand the existing requirements that are already out there, but this data was based always on where the citations were being issued. So it's not just for healthcare. It has some in some industries, but it also has meat packing and so on and so forth. So these will look a little bit familiar from the top 10, but there are a few others. Again, they're not numerical in order. They will go out of sequence, but again, it's based on which citations were issued. So once again, respiratory protection was the #1 citation. Employers did not provide a medical evaluation before the worker was fit tested or given a respirator. Here is that other language that I was referring to. The Appendix C, the medical evaluation was missing something. So you can certainly refer back to the 1910-134 regulation, also the directive for the respiratory protection compliance may have the medical questionnaire in both English and Spanish if that's a resource that's of benefit to you. Section F, as in Frank, the employer did not perform an appropriate fit test for a tight-fitting elastomeric face piece respirator. Again, also filtering face pieces can now be fit tested as well. So the employer did not ensure that an employee was fit tested prior to using the respirator for the first time, and it needs to be the same make, model, and size. And annually thereafter. I will tell you, in one brand of respirator, I'm a small, and a different brand of respirator, I'm a large. I have not gained or lost 10 pounds since those two were done, but even just a simple weight change of 5 to 10 pounds can make a difference, as well as facial hair will certainly make a difference, and you cannot impede the seal location on the face. So that is something that your facility will have to monitor if staff does, and provide an alternate, or again, that employee needs to not enter areas that would be requiring of respiratory protection. The employer did not administer a fit test using the protocol in Appendix A of the standard. And again, the Appendix A would be referring back to 134. And here's that. Again, I'll just hover over some of these, that some of these are videos that the agency has put out, and you could certainly use them during your training sessions of how to properly put on a respirator, take off the respirator. These links are all good. I checked them again yesterday. The respirator program, I'll just do the number one. That they, actually, I wanted to review all three. The employer did not establish, implement that respiratory protection program with that work site specific procedures. And again, this would be during the pandemic, so droplet precautions and respirable airborne stuff for the virus. The employer determined the voluntary use was permissible but did not provide the information as required from Appendix D. The employer did not designate a qualified program administrator to oversee the respiratory protection program. Again, during the annual review, this would be something that at one point in time, the program administrator was, you know, XYZ, but now it's ABC person. So that is something that needs to be updated according to as required, and updated as soon as possible. Training information, the employer did not provide effective training and basic information as described in Appendix D. The employer did not ensure that the employees could demonstrate the knowledge of the respirators when they're necessary, how improper fit and usage and maintenance can reduce the protection, the limitations and the capabilities of the respirator. For example, filtering cartridge respirators, the cartridges can be used for more than an 8-hour shift. It's just a matter of the employer needs to determine the maximum concentration or maximum week time frame, or however long, to determine that. How to inspect, how to check your seal, procedures for maintenance and storage. You can't just put it, you know, in the back of the trunk. It needs to be properly disinfected, and how to recognize which signs and symptoms that may limit and prevent respirator use, as well as the general requirements. The employer did not provide the training before the worker use the respirator in the workplace. So that is something that needs to be covered. Again, under Section D, let's move forward to that the employer did not select a Niosh certified respirator. And here, again, we'll take a pause and say that, yes, last year, there was a lot of recognition of international respirators when U.S. supplies and Niosh certified respirators were not available. But we are now in pandemic year 2, and there are Niosh certified respirators in available. What I will say is that the employer does need to make sure that the price of supplies you're requesting and paying for isn't too good to be true, because again, we have seen fraudulent Niosh certified respirators. Again, unfortunately, it is something that the employer has to keep abreast of. There are some unscrupulous distributors, so that is something that the employer is always responsible for. So again, when a Niosh certified respirator stock comes in and it just doesn't seem right, again, the labels don't match, you know, the information is inconsistent with what's on the individually marked respirator, the respirator isn't marked, the Niosh certification stamp is not the appropriate TC number, you know, so on and so forth. So these are the things that an employer would benefit from training the employees to recognize, look for, as well as, again, I had seen a very detailed white paper on, again, some fraudulent filtering face piece respirators. And it was saddening to see because, again, workers think they're going to be protected at the N95 minimum level, and they're not. So again, the employer does not select and provide an appropriate respirator based on the respiratory hazards for which the worker is exposed. Permissible exposures. They did not provide an adequate respirator for when necessary. Again, if the assigned protection factor is a factor of 25, or does it need to be an assigned protection factor of 50 or 100, you know, so on and so forth. Last year's guidance was very much based on high hazard procedures and so on and so forth. The guidance now, and we'll get into it a little bit further with the other documents, the employer needs to make the determination of what hazards are going to be exposed or determined to find which hazards are going to be where in either the facility or during which procedures. Again, medical evaluation did not establish adequate fit test records, including, you know, the so on and so forth, what needs to be part of a fit test record. Last item under section 134 is the maintenance and care of the respirators, storing respirators properly in a way to protect them from contamination, deformation in both the face piece and or the exhalation valve, if appropriate. Again, sometimes the exhalation valve needed to be covered at a time last year, but again, now we're getting away from that. Under the subpart 1904 for record keeping, the employer did not report a fatality to OSHA within 8 hours after the death of an employee. That was a work-related incident. The employer did not keep records of fatalities, injuries, and illnesses that work-related. And again, we're going to get into a little bit of the criteria in a little bit, but the employer does have to demonstrate that it is not work-related in a healthcare facilities during a pandemic. Again, the controls have come into standard practice, and it is possible that the employer may erroneously determine that, oh, well, it has to be community-based. It's during a pandemic, whereas your employees work in a healthcare facility that are known to take care of patients that could have COVID, or there's no patients that had the COVID, but you have a cluster of 5 or 6 employees that are out. So again, there probably was a work-related item and a few cases that would need to be recorded. Back to personal and protective equipment, the employer did not assess the workplace to determine if hazards are present or are likely to be present, which would require it. The use of PPE, selecting and requiring the use of personal protective equipment, effectively communicating the selection decision to each of the affected employees, and selecting the PPE that properly fits employees. Again, you have staff in different shapes and sizes. This would be the opportunity to make sure that the personal protective equipment fits properly to different size employees. Properly documenting and writing the required hazard assessment. And the employer did not provide, use, and maintain in a sanitary and or reliable condition. And again, here are CDC guidelines on the use of medical face covers, eye protection, isolation gowns, and so on and so forth. So by not printing and just having it as an accessible document, you can link right to that specific page. Lastly, but not least, the employer did not furnish a safe place of employment that was free from the recognized hazards. Again, the general duty clause is that employers must protect employees from the COVID hazards at the workplace. For example, by not installing proper plastic barriers and ensuring social distancing. And again, there's very specific industry guidance now, both on the OSHA page as well as the CDC page. Again, this was the temporary enforcement discretion that was current at the time of publication in December. There we go. And a different document, it's sort of a one-pager. Again, it's a good primer at the time of publishing November 2020. Again, if your employees was not, employers were not doing what they were supposed to do with regard to respiratory protection. There's about 9 items on this one-pager. And again, it very much, the blue words are the ones that we're going to be reviewing here. Medical evaluation, fit testing, respirator, other personal protective equipment, establishing, implementing, and then not forgetting that updating as needed when more work site-specific procedures were identified, because again, you've done some in-house investigations and it's shown that in this area of the building, or, with our dementia patients, we need to do, X, Y, Z more so than in, common eating rooms, where, if there are even common eating rooms again yet. Providing the appropriate respirator, training employees to use the respirator, storing the respirators. Again, it's a good one-pager. Now, in January 2021, President Biden put forth an executive order for the agency to do clarifying in COVID prevention programs, and this document, I believe, is a one-pager. So we have issued the revised guidance. We're considering an ETS. We have evaluated and developed and published a national emphasis program, and we're working on providing more multilingual outreach material to best serve employers to help protect most of the vulnerable and impacted workers. What the revised guidance details is that implementing that prevention program tailored to each workplace. Again, what I had referenced earlier about getting away from the categories, the employer needs to tailor it to each workplace. Engaging workers and their representatives in program development, and what that program should include. Again, it's terminology we've reviewed in various forms now, but we'll do it once more by saying that for the COVID prevention program, it should include a hazard assessment, a combination of measures to limit the spread of COVID-19 in the workplace, measures to ensure infected or potentially infected workers are excluded from the workplace, be it temperature checks or other forms of screening at the start of the shift, during the shift, or even at the end of the shift. Protection from retaliation for workers who raise COVID-related concerns. Again, the whistleblowers.gov is always an accessible webpage for each and every employee, and its whistleblower protections is in the OSHA Act as in the Section 11C statute, but yet it was very specific in revised guidance for COVID-19 published in January of 2021. Employees only have a short amount of time to report any retaliation to the OSHA agency, and so it's very time sensitive. Once again, the reminder of educating and training workers of the COVID-19 policies, procedures, and/or precautions in a language that they understand. The best resource page that I can direct you to for that information is the OSHA.gov coronavirus. There's also a means to sign up for the COVID tip of the day. I believe now it's just called the safety tip of the day. So if that's something you're interested in, I can certainly direct you to it. The National Emphasis Program was published publicly, and it is available under the directive number listed on the page. and it was issued March 12th, 2021. So that goal of the NEP, as we call it for short, is to substantively reduce or eliminate worker exposures through a combination of inspections, outreach to employers, and the compliance assistance that we're getting and giving today. That focus is primarily on the establishments that have put the largest number of workers at serious risk of contracting the coronavirus. And once again, to prevent the retaliation against workers who complain about unsafe or unhealthy working conditions and or exercise this and other rights. So the focused enforcement will be on industries and work sites with tasks that have high frequency close contact exposures and with increased potential exposure. And we'll be using unprogrammed, programmed, and follow-up inspections to do it. It replaces that May 26th, 2020 guidance, and it helps identify exposures to COVID-19 in the document, as well as ensuring that appropriate control measures are implemented by emphasizing it. It doesn't say which measures need to be implemented because, again, is always determined by the facility and or the employer with the input of the employees. And it addresses OSHA violations and looks also to apply the general duty clause, which again is the general requirement that all employers shall furnish a place of employment that was free from recognized hazards or likely to cause hazards. It does not have a sunset date at this time, so it will remain in effect until further notice. It prioritizes on-site workplace inspections where practical, or providing some allowance for a combination of on-site or remote inspection methods. So a compliance officer would make that decision as appropriate. COVID-19 related inspections involving deaths or multiple hospitalizations, complaints, referrals, alleging potential exposure to COVID-19 would also be something that we would look at. Again, it would fall somewhere in the unprogrammed or programmed. Using the remote methods to conduct employee interviews and collect documentation to minimize that person-to-person contact. OSHA recognizes that the medical care is most important, so we do what we can to limit interruptions to that type of work. It supports the NEP by implementing programmed inspections and targeting industries where OSHA has previously identified increased enforcement activity in the NAICS code, which is the North American Industry Classification System. Years ago, it was the SIC code, the Standard Industry Code, I believe, not system. So we'll get into which NAICS are on this NEP list, and it provides specific inspection and citation guidance for all COVID-related 19 inspections, and it gets into a little bit of that, and that's more for the compliance officer. If it's of interest to you, on page 24 of that document is the page that has the health care NAICS. And again, just a few of them are the home health and the home care services, ambulatory services, nursing care facilities, assisted living, continued care retirement. So again, if you don't know what your NAICS code is, this may be a time to just Google NAICS to SIC or SIC to NAICS, and then you'll be able to find that as well. On Appendix B, on Table 2, is the targeted industries for non-health care. Again, not likely, it might be some of the people on this call, so I will bring attention to meat processing, animal slaughter, poultry, supermarkets. Again, the general warehouse and the temporary help services. Again, temp staffing, should you hire employees out of, for some of the per diem work or temp help, then this would be something that would be relevant to your. If you provide contract work to correctional facilities and their health care and or dental care or so on and so forth, that would be something that you'd be aware of. So that is a very brief review of the exposure control plan, NEP. We're going to do a very quick exposure control plan review, HAZCOM, and the record keeping again, and then we will close it out. I know it's been a bit of time sticking with me, and I appreciate it. So the elements of being compliant with 1910-1030. Again, we've reviewed some of them, but you do need to prioritize which part of the facilities might have health and or bloodborne exposures. Universal precautions is always required. Engineering controls and work practices and implementing such. And last line of defense would be the personal protective equipment. We'll get into deficiencies in housekeeping, again, that hepatitis B declination and or vaccination, how it relates to HAZCOM, and then that record keeping item. That key provisions is to determine which employees have that exposure, because those would be the employees who need to be trained. Again, sharing why we have not eliminated the hazards with engineering controls and gone with personal protective equipment, which requires the employees' active participation to use it. And again, vaccinations, in this case, it's just for bloodborne. Reviewing and updating it at least annually. Again, when I did my inspections, this was something that I definitely found. So again, I felt the need to mention it again. As required by the standard, and again, most employers didn't understand what I was referring to, so I wanted to put the section right here that when you establish an exposure control plan, you shall, not should, but shall solicit input from non-managerial employees responsible for direct patient care who are potentially exposed to contaminated sharps, identifying what alternates they can use for those engineering and or work practice controls, and marking it and documenting that solicitation in the exposure control plan. And I often shared the thought of, if these are the employees who have to use the personal protective equipment or the work practice controls, then they should have input, and it's required by the regulation. So employers then became compliant after I cited them. Under the housekeeping, written cleaning and decontamination schedules are very important, because certain disinfectants have required certain contact times. And I will relate this back to the COVID EPA listing, but again, it's most relevant in the bloodborne standard, and making sure your contaminated waste and disposal methods are adequate, your frequency of changing out your sharps containers, so on and so forth. What is full? Yes, these were conditions that were seen, possibly still seen, due to, again, things that were not adequately addressed at facilities. So 3/4 full is full. It must be then closed and not sticking out. And is the sharp, safer needle containers readily available at the patient care stations? Again, is it a single-use syringe or a phlebotomy draw needle? And there are different containers for different situations, so it's not a one-size-fits-all. Splatter has become an issue with not only COVID, but also in other types of facilities. So that's but one example of a splatter control. I'll pause here to show EPA's list N for COVID-19, which again is not a bloodborne hazard, but the point here is that the contact time are different numbers and different allowances. They range from less than a minute contact time or soaking time up to 30 minutes. So while the ingredient and or the label might say, oh yes, it's a COVID-19 approved disinfectant, please be aware that the facility and the employer must do a little deeper dive into the information by reviewing the technical information pages to determine, is this going to be an effective disinfectant for our facility for the type of work that we do. Not sure your room can be out of service for 30 minutes. Not sure your employees are trained to know that the disinfectant needs to be left on your surfaces for 30 minutes, again, using the COVID-19 example. So when I did a search back on March 10th, 2021, yes, wonderfully, we have 537 listed disinfectants that are choices to be used protective and sold clearly and legally as being a registered COVID-19 disinfectant. When you actually select less than 1 minute, you're now down to 104 listed disinfectants. If you select less than 5 minutes, you now have 283 disinfectants. So that is something that, again, the compliance officer would want to talk about with employees during NEP for COVID-19. Do the employees know that this particular chemical with this particular brand name is, going to protect the employees and how it's protecting employees? And this is one of those industries that not only are you protecting your employees, you certainly are protecting your patients and your public stakeholders or other cared for. So not just as an example, you cannot just use the name recognition of using Clorox, because I did a search on Clorox and I found a variety of Clorox ingredients, but some were at, say, 3 minutes and for the norovirus, and then the other one was for a feline, equivalent disinfectant, and that was 4 minutes. So 3 minutes and 4 minutes may not seem like a big difference, but it's very specific to the chemical and the active ingredient. So what this means is that you definitely need to verify that the products you're ordering are on the registration list, be it for hepatitis B disinfectant, TB, or MRSA, whatever your registrant list you're referring to. Check the safety data sheet. Do I now have to, do some more effective safety and health training? Different safety and health training. Again, some of the registrant information might not be on the safety data sheet. I would actually suspect it's not on the safety data sheet because it's a very specific sheet. So you could possibly find it on the label. I would recommend looking at the technical information page and going, for a little bit further. When reordering supplies, again, this was very much an issue last year. Look beyond that first name recognition. Not all cleaners and disinfectants are the same, as you can see. They could all be listed as COVID-19 registered EPA disinfectants, but 1 minute is not 30 minutes for certain. And then how does that impact your compliance with HACCP training as well as personal protective equipment? Again, it was very clear years ago that the cleaning and disinfecting may not have even been done by in-house staff. It may have been subcontracted out. Now, during the pandemic, we're doing a lot more house count cleaning as required because we can't wait for the end of day. We need to flip this room. So EPA published a very helpful one-pager. We'll just briefly review it in that we're checking that your product is certainly EPA approved. We're reading the directions. We're pre-cleaning surfaces as appropriate, following the contact time. And then, again, obviously wearing your gloves, washing your hands post-use, and then locking it up for non-contact to people who shouldn't be touching cleaning chemicals. Quickly, written program, knowing your cleaners, proper selection based on your facility, and this goes beyond bloodborne pathogens, obviously, as we referred back to the COVID-19 NEP. For the record keeping, once again, it's the requirements as we reviewed earlier. Want to be able to get through the page and get to some of these questions, so I might go a little bit faster. Here is that reference link that I was mentioning. You could certainly call the nearest OSHA office during normal business hours, which for most facilities is local time of 8 a.m. to 4:30 p.m. The 1-800-321-6742 is always available to you. And the reporting online page is at osha.gov, report online. Now, for COVID-19 enforcement, Memo referred to record keeping and reporting pre-May 25th, 2020, and then after May 26th, 2020. And those enforcement memos for recording cases of COVID-19 are still in effect. Again, as far as I could have checked this morning, they were. So it is recordable if the employers are responsible to, it's a confirmed case of COVID-19 as defined by the CDC. It's work-related as defined by 1904-05, and it involves the general record-keeping criteria set forth under 1904.07, meaning it has days away from work, lost time, or it would be column 6 entry. And certainly, most of the cases, if workers need to be restricted in some way, shape, or form, then it's going to be recorded under 1904-07. May not be lost time if they can do work from home, but they can't come into the facility or, again, whatever the record-keeping criteria are. I circle it back to hazardous communication because there has been some confusion as to the different programs that are out there and how they all interrelate. So again, employers have asked me to dive a little deeper into the HAZCOM 2012, how it relates to GHS, and again, because we all have acronyms and abbreviations, why not just add NFPA and HMIS? And we'll get into some pictograms of that so you know what I'm talking about. Globally harmonized system is an international system. Again, it was very relevant in recognizing that we have international shipping, receiving, importing, and distributing in the United States. GHS is not the OSHA hazardous communication standard. What happened was GHS is the international system. It updates every 2 to 3 years. HAZCOM 2012 came into alignment with GHS 2, almost 3. The international system is now on revision 789. I say that because it's almost always promulgating. Again, if it only takes 2 years to promulgate the new standard, it's sort of what's already been issued, what's the newest revision, and what's already going to be published in the next one. So we recognize that there's about 9 pictograms, 8 of which relate to safety and health in facility issues. So that 9th one, and again, there's a picture of it, but you don't need to have this in your facility. But if you do have a diamond on your containers in-house, these would be the only not 8 options. For example, this was what a label would look like that is compliant with Hazardous Communication 2012. The warning label is allowed. It could have warning or danger. There isn't any allowance for any other words anymore. But the HMIS and NFPA labels are out there. They're allowed to be used. The agency did not prohibit them, but it cannot cast doubt or contradict the validity of what's already on the OSHA information label, either on the safety data sheet or what's on the shipping label, and then an employee in shipping and receiving puts it on different labels. So the level of employee awareness must be equal or exceed if the employee were to be provided the complete health effects information. Again, the HMIS label is recognized as, again, it's short, it's sweet, it's a very easy numbering system. Everybody likes the numbering system, but it is in direct contradiction to the hazardous communication, which again draws its information from GHS. What that means is what used to have reactivity now even itself has physical hazard label. So that's even a subtle difference from the yellow to now orange, as well as the numbering is directly opposite. So on the left is the HMIS NFPA numbers, which is 0, minimum hazard, but the hazard numbering system is not the same. This is not the information. It is this. Least hazardous is 0. Least hazardous on HAZCOM 2012 is number 4. So again, that information is inaccurate. This information is where you can sort of see where the numbers can be transferred erroneously from the safety data sheet or a GHS label if you get it internationally, and put on your HAMIS in-house placard, and it's incorrect. So Hazardous Communication is looking to align itself with the newer version of the globally harmonized system and updating it with some subtle changes. So we are actually in a proposed rulemaking phase right now. If you're looking to get information, suggest going to the OSHA.gov HASCOM page and then looking for the rulemaking button. It is over here on the right. It's on the top section. There was a joint meeting on DOT and OSHA with the Geneva group of the UN to, again, try to compare and get the labels to be more in alignment. And hopefully they'll resolve this in some way, shape, or form. Again, we'll see what the revision is, but this is the opportunity of each and every stakeholder who wants to have their voice heard. Your comments get put into the preamble and compiled into feedback as to how to improve the compliance and the requirements of the hazardous communication so that workers are protected. And the last thing I will say about HASCOM is that there's no more caution labels. We've completely removed that, and I haven't, in my safety audits for safety and health program reviews, I haven't really seen any caution labels. But again, in-house labels is where that concern was. Luckily, there's information that you can see on that page as to where to go look for the comparison of that NFPA 704 to the HASCOM 2012. Last but not least, in healthcare, we certainly recognize the need for the exposure of employees to workplace violence. It is a little bit of outdated data on the chart, but the chart is still accurate in that far and away healthcare and social services, more so than any other private industry, retail, construction, or manufacturing, workplace violence is very much an ongoing issue. When it's done in different graphics, you can certainly see that healthcare and social assistance, more than arts and entertainment, more different from retail, education, and again, transportation, warehouse, and waste. The top 5 injuries that report worker injuries from workplace violence. And this data is not OSHA's data. It is our sister agency, the Bureau of Labor Statistics, BLS. When we have done deeper dives into where the source of it is typically the patient. Again, during some safety and health assessments of different healthcare facilities, they have done an assessment based on different floors or different departments, and they found that not only was it just patients, it was their dementia patients that were being the most, violent. And again, it just was a matter of retraining and having a good, effective program to help that patient transition to the next activity. And then they saw a trend in the opposite direction. It was much more safer for the patient and then safer for the workers as well. So again, this is a little bit aged. I'm not sure if Bureau of Labor Statistics will be updating it in, say, 2023, but again, it's not an outside person. It's not a coworker. It's not a student. It's not a client or customer. It's the patient. So that's a really old, outdated, I shouldn't say outdated, it's an older document. Again, if you really are feeling overwhelmed and want just one thing to start with, for medical and dental offices, this is the compliance guide. It reviews 6 of the standards that we've talked about other than ionizing radiation, and it's more for the X-ray machines. But other than referring to MSDSs instead of safety data sheets, it's still pretty accurate as to what employers can do to provide a safe and healthy workplace. And again, I've had some facilities staff say, okay, my employer is doing nothing. And I'm like, oh, you could just leave a couple of those copies of the trifold around and see if it makes a difference. And then, again, that information plus, a couple of OSHA posters around could certainly go a long way to helping the employer know that, maybe I should look into this OSHA thing. Again, employers responsible for providing a safe and healthy workplace. And again, based on the citations of the frequency of the top 10, some employers still haven't gotten the message. Best place to get OSHA information that's as timely is the OSHA Quick Takes. Again, I think we don't have enough subscribers, but twice a month we will mail out information as well as make it in a mobile device friendly format, as well as that OSHA tips of the day that I was referring to. OSHA poster, it is required by law, and it be posted at the work site. It be a state equivalent. Again, so if you're in Maryland and Virginia, for example, you can put up their OSHA poster and it'd be just fine. You don't have to put up the federal OSHA poster if you're in those two states. Even though we pivoted to virtual and non-in-person activities, we did quite a bit of work last year. We responded to a lot of phone calls, still responding to email requests for assistance. Again, not every OSHA contact needs to only be an enforcement inspection activity. You're more than welcome to contact the OSHA regional offices for assistance. And you can do, we've been able to pivot to virtual and online and go to meetings and Zoom and do some outreach activities from both the regional and area offices. Now, small business consultation. I think it's an underused, undervalued, confidential, free service for small businesses, less than 100 employees, which again, most employers in the United States are. The no cost comes from the fact that the OSHA penalties are not paid to the local area office. It is paid into the state programs to fund these no cost OSHA consultation programs. It's available to all small, medium-sized companies. It's prioritized for high hazard, which again, healthcare at this time is based on, again, the hazards we've just reviewed. It's available in all 50 states, the District of Columbia, and several of the territories. It's independent and separate from federal OSHA, so that's where the confidentiality element comes in. It is run by state agencies or universities, and it truly is separate from OSHA enforcement. So again, if you just wanted to put in a request saying, hey, I see that there's a national emphasis program on COVID-19. I don't think my program is adequate to protect my workers. Would you mind coming in and helping me with one or two things? You can make it as small of a request or as large of a request. Because it is a free service, there may be a backlog in your state. There may or not be. So the only thing that they ask is that you fix whatever they find. So that's why you can limit the scope of the visit. They, a number of years back, there was a white paper on the economic benefit to using consultation. There was over 26,000 visits. Almost 90% of the businesses that used the service in all of the 50 states were businesses that had 100 or fewer employees. Quite remarkable, removing 2.9 million workers from hazards. So those workers were able to go home 10 fingers, 10 toes, safe and healthy at the end of the day. Such a wonderful service for free, and saved $1.3 billion to both the workers and the employers. In the Mid-Atlantic states, in our 6 jurisdictions, here is the local contact information. So you can see it's West Virginia, it's one out of the state. In Pennsylvania, it happens to be run out of a university, IUP, for example. Even in small space such as Washington, D.C. has their own state consultation program. So if the scope, as I said, was determined by you, whatever you need or want. If you need noise monitoring, or if you need some sampling in one specific area, you could have them do that. Hazard identification and an expectation of correction. Developing your safety and health program. The service is free. And again, it's by law that it's free and confidential, and it's exempt from OSHA program inspections while the visit is in progress. And or if you want them to come in and just refresh your training, they can provide some of that training and or technical assistance for you. Switching gears ever so slightly, we can go and show that OSHA has a YouTube channel. And that's where you can find the OSHA videos that I was mentioning earlier that were linked in that common citation document. Because we are in the Commonwealth of Pennsylvania, I will let you know that we are segmented into 6 area offices, and they are on the screen at this time so that you can see that. Again, you could even call the local OSHA office if it's something specific to your area, be it in Crawford or Erie County, Allegheny and Westmore, or Luzerne for Wilkes-Barre, and or the Commonwealth capital near Lancaster. Oh, yeah. So help you feel that we have reviewed and compared the top 10 hazards for all industries with the Health Care NAICS code and their top 10. Hope that feel we got a good review of the common citations that employers are being cited for and compliance officers are seeing due to the COVID-19 exposures. And we got a fresh perspective on the National Emphasis Program that was issued on March 12th, 2021. And again, we identified some compliance assistance resources in all of those sectors. If you're looking for contact information, again, we went through this throughout the presentation. I won't linger here too long.
Okay. Well, thank you, Isabel. That was a lot of information.
We said it would be.
We did. But I think this was some really great stuff, and we do have several questions. So again, if you have a question, please type it into the Q&A box or the chat box on the right-hand side of your screen. If you don't have those boxes, you can see in the bottom right, there should be a little bubble where you can select chat or Q&A and type your questions in there. So we'll get through as many of these as we can. I see up on the screen is the information about the continuing education certificate. If you, Isabel, you're still sharing.
Yeah, I'm trying to, yeah, there we
go. This educational program will provide a certificate for education for 1.5 hours for registered nurses only in Pennsylvania. You'll have to complete the SurveyMonkey evaluation in order to get that certificate. So let's jump into some questions. Isabel, can you talk about the OSHA position on maintaining SDSs electronically, i.e. hard copy versus cloud-based and online services?
I can just say that from a non-enforcement point of view, because again, I haven't looked to see if there's any new interpretations on it, as long as they are accessible, I think it's going to be okay, but the employer needs to verify that that information of that baseline is being shared with, did you say STSs, which is a standard threshold shift specific to the 1910-95 regulation, and then how it relates to record keeping and whether or not it's recordable. I think you can, but the employer needs to be able to show that whomever did the comparison this year had access to both the baseline or the revised baseline to this year's test so that, again, the comparison is accurate. It's not just, oh, we changed contractors and let's say I've had an employee for 10 years. Well, this new contractor, audiogram company, only has 5 years of my data. So again, it has to be, yeah, it's possible, but be very careful to make sure all of the information and all of the baseline data is available to that assessor.
You talked about reporting hospitalizations, and there was a question about, does this include patient hospitalization or only for staff hospitalization?
Staff only, employee-employer relationship. Excellent question. Thank you.
Okay. Employees who receive the COVID vaccine and they become hospitalized, is it required to report that to OSHA under the 1904.39A2?
Again, I would recommend just reporting it. It's possible that there was a different type of reaction that isn't work-related, but yeah, reporting it. If it is an employee who has a inpatient hospitalization, yes. I mean, again, I go back to the heart attacks. More than likely not work-related, but you're better off reporting it and then letting OSHA just do its own, short investigation, which is different than an inspection.
Can you share a good example of the PPE hazard assessment?
Let me quickly search. I'm almost positive there is one online on the OSHA page, but I'm quickly searching. I see some people sent me a private question. I may or may not be able to get to those in the next 4-6 minutes. I will. Sorry. I was like, oh, look at that. Those are private questions. Okay. Yeah.
We'll get through as many as we can. While you're
As much as
looking
we
for
can.
that, I saw a couple comments about fit testing and that people are really having a hard time getting the same mask to do the fit test part in that the staff are going to be using, because that seems to be changing. And then the fit testing, that annual fit testing requirement was waived for 2020. Do they need to do an annual fit test in 2021?
Yeah. And again, what the employer could or should do is when it is, a time allocation as well as a supply issue, get it done sooner rather than later, because what's the reasonableness of it issue here? Again, if you normally historically did it in February of 19, and then again, February, March of 20, we all got pandemic busy, and now it's February, March of 2021, and you're sort of skipping it, thinking we're not going to cite it or look at it, again, what's reasonable? So I'm still looking for the hazard assessment.
Yep, you're fine.
There's a old OSHA hazard assessment advisor page on the OSHA page, but not specifically just to 132 personal protective equipment.
Okay. Here's another question. Is a written respiratory protection plan required in an ambulatory, like endoscopy center, if N95s are not required at this time?
I would like to have that facility consider that we are in a pandemic and it's filtering face pieces might be something that the compliance assistant staff, not compliance assistants, compliance officer would look at as to why that facility made that decision. On the information provided, if an employer has made the assessment that no, we don't need respiratory protection, then no, a respiratory protection program would not be required.
Okay. Has there been any change in OSHA's 2004 position related to adverse vaccine reactions for smallpox in light of the current COVID-19 vaccine, assuming they meet the general recording criteria?
That was an interpretation, clarification based on just for smallpox, but again, loss of consciousness is recordable. It's the most common reaction.
What is, or where could they find the latest guidance on mandating COVID-19 vaccinations for employees of a health organization?
And that is very much a moving target. You can do it on the quick takes, the OSHA tip of the day, and or that OSHA coronavirus page. Also, it's just for federal OSHA. Your state may require something different. Your corporate company might require something different. So your industry might, make a different determination. There, again, if you're category 1A, which again, the OSHA agency wasn't category 1A, we're category 1B and 1C. So the at this time is very timely. So to get the most current information, you could certainly go to the OSHA.gov page and the CDC pages.
There's a comment that one of the links isn't working correctly, and I'll get that to you so we can get that fixed.
Oh, thank you. I appreciate that.
Yep. Have you seen citations regarding the guidance that employers should not be distinguishing between workers who are vaccinated and those who are not?
I have not seen any because I don't see the inspection data and I don't see those complaints. I've not seen anything on that distinguish yet.
Okay. On slide 20, it says, I thought new research showed that plastic barriers are not effective against COVID spread. And why does OSHA recommend this barrier if it hasn't been proven to prevent spread?
Again, it was based on CDC guidelines at the time of issuance of that citation.
Okay. If an employee dies of COVID, how can you say it's work-related?
Again, what's reasonable? And it's not the dying. Unfortunately, the dying is not what makes it recordable. It would be recordable if they were asymptomatic and it was a positive COVID. It's did they miss work, days away from work, and you know, communicable transmission at the workplace. So the employer has to do an investigation to determine why they think it isn't a transmission that was acquired at work.
So the onus is on the facility.
Always.
Always. That's good. Good tagline for you. How can you keep nurses at the nursing station 6 feet apart?
That's a very good question. Again, that is a very good question. Again, I was very interested. I worked on an ambulance. You're not going to be 6 feet apart, but again, it's the face cover, and when you can, 6 feet apart. But again, your work practice and the medical care comes first. So that the employer has to show why they can't do the 6 feet, and if the nurse's station, they can't do it, or they have to have all the nurses there. What's reasonable?
Well, we are actually, I think, a little bit over time. So I'm going to let you go and everyone else go. Again, CE certificates are available. Don't forget to complete your evaluation at this link in order to receive that credit. If you have any questions or issues with the evaluation, please feel free to reach out to Shelley Meixel at shmixell@pa.gov. And that concludes our webinar.